for this talk. My topic was on TAVI hemodynamics, post-TAVI hemodynamics, and I believe this is more important even before we start the TAVI procedure that we need to understand how a hemodynamics of a patient will look like. So here is a patient who has undergone a valve-in-valve procedure, and you can see the post-valve-in-valve deployment. You see a peak-to-peak gradient of almost 40 millimeters of mercury. Now, a few things. This patient has a 19 millimeter epic valve, and we put in a 23 millimeter evolute R. And for a smaller valve, we need to choose a supraannular valve in order to have better hemodynamics. But this peak-to-peak gradient is not acceptable, and such patients need post-dilatation. Now, let us also look at one more case scenario. 76-year-old lady, weight of 110 kilogram, height of 5.6, BSA of 2.2. Now, if you look at the dimensions based on the area, patient will require a 20 millimeter balloon expandable valve versus a 23 millimeter self-expandable valve. Now, if you put a 20 millimeter balloon expandable valve in this patient will end up having a patient process mismatch just because she is very obese, and obesity is a predictor of increased cardiac output and increased patient process mismatch. So this is very important. Even before we do a TAVI, we can actually predict a hemodynamic of a particular type of valve which will be selected. For this patient, again, you choose a 20 millimeter balloon expandable versus a 23 millimeter evolute R. Patients with smaller annulus and large body surface area, a supraannular valve is preferred. And this is an example of valve deployment in this patient, 23 millimeter valve deployed at the right depth. Now, for the first patient where we saw a peak-to-peak gradient after doing a valve-in-valve case, where it was already 20 millimeters of mercury, we need to do a rapid pace at almost 180 to 200, and then use a post-dilatation balloon. A post-dilatation balloon is 1 millimeter, one size bigger than the size of the bioprosthetic valve. And here you can see a peak-to-peak gradient of almost 12 millimeters of mercury, and mean gradient will be single digits, which is an acceptable result in patients. So now everybody knows about majority of the problems with the TAVI have been fixed. Just few things which are still remain to be fixed in patients. One is a stroke, and another one is a pacemaker. And pacemaker is still coming down to the single digits, but the most important thing is the durability and the hemodynamics of the patient. We all know from the surgical literature that the patient process mismatch is a poor predictor of outcome, even at short-term and long-term outcome. And it also does not allow the regression of the LV diastolic dysfunction if patient continues to have patient process mismatch. I'm not going to go into this slide because it's been presented multiple times. Supraannular self-expanding valve has more effective orifice area, lesser gradient, and definitely lesser chance of patient process mismatch. Patients with severe patient process mismatch have almost 20% mortality compared to patients who don't have severe patient process mismatch, which is 12. So it is very important for us that we can actually tailor the valve to two things if we need to have good outcomes in a TAVI patient. Number one, you tailor the valve to a TF approach. Number two, you tailor the valve so that you can avoid patient process mismatch. This is also clearly which shows that patients who have severe patient process mismatch compared to moderate to mild patient process mismatch have higher mortality even after TAVI. This is more important in patients who undergo a valve-in-valve procedure, especially for the smaller annulus. Now, this is a very important slide. If a patient has got a smaller annulus, which is less than 23 millimeter valve, a supraannular valve will prevent patient process mismatch until unless the patient is very lean and thin and a very octogenarian or a nanogenarian patient. Valve-in-valve procedures, if the bioprosthetic valve frame cannot be fractured, and if the bioprosthetic valve is a very small valve, again, a self-expandable supraannular valve is better. Again, we all know, because I'm not going to go into detail, but we all know about this slide, supraannular, intraannular valves. Again, the effective orifice area of a supraannular valve is more than the effective orifice area of an annular valve. And this becomes more important in the smaller annulus patients. Now, if we have a patient who has got a very small annulus and patient is obese, there is no doubt that the self-expandable valve will give us more effective orifice area and lesser patient process mismatch compared to uh, a balloon expandable valve. So for valve-in-valve procedures, hemodynamic optimization is very important. If the hemodynamics is not appropriate post-procedure, we need to do a bioprosthetic valve fracture or post-dilatation using a balloon. I'm not going to go into detail. That can also be discussed. So hemodynamics plays a very important role because majority of questions in the TAVR field have been answered, and one which still remains unanswered is the durability. Now we have data of almost 8 years from the Notion trial where they used first generation core valve for all comers patient. And at 8 years, the structural deterioration in the TAVR patients is lesser compared to the surgical population. So we have to still wait for the long-term data. But clearly, if the hemodynamics are better at the beginning, probably those leaflets will last longer because those leaflets have less stress on them, and probably they're going to have a lesser structural deterioration. Again, we know this data again from the partner trial as well as the core valve high risk registry. 5-year effective orifice area of a supraannular valve is more than the effective orifice area of an annular valve. Now, this I already discussed from the Notion trial. The structural valve deterioration at 5 years was 26.7% in the surgical population versus 9.3% in the TAVR population. Now we have data up till 8 years, and it clearly shows that the TAVR valve is going to last as long as the surgical valve. Just one last example, 48-year-old patient, prior history of MVR, severe AS, 150 kilogram, obstructive sleep apnea, prolonged ICU stay during the first surgery, labeled as inoperable to high risk, was referred to for TAVR. But look at the body surface area of this patient. It is 2.7. Clearly, if you put a valve which is supraannular, the effective orifice area will be better, the mean gradient will be less, and most important, the patient process mismatch will be less. And similarly, a 34 millimeter valve was put in this patient, and patient was discharged home on the next day. Summary: optimal hemodynamic performance has been shown to affect the clinical outcomes and has been used as a benchmark for surgery and TAVI success for decades. Clinical trials consistently show that TAVI with supraannular valve has better effective orifice area and better hemodynamics, and they achieve larger EOAs. Patient process mismatch may affect the valve durability, and we need to wait for the long-term data. Thank you very much for your kind attention.